Let's start talking about the implications. So what do we know about the relationship between post-PCI IFR and subsequent adverse outcomes? Because you don't have your outcomes data yet.
Right.
We have relationship between post-PCI FFR and outcomes. So do we need to wait, before we get concerned about these results, do we need to wait until we get 1-year outcomes data?
Well, in general, I think as interventional cardiologists, you're trying to achieve an optimal outcome, right? And we have to find optimal results based on the angiogram currently. I think we have to change our thinking a little bit to define optimal outcomes based on physiology, as the study indicates. Now, the clinical implications, I don't think we have great data at this point with resting indices post-PCI, which is why the study will be interesting and instructive. But having said that, I do not think that there will be a difference between IFR and FFR in terms of long-term outcomes when there is significant ischemia.
I think the other thing we're waiting for, I think will be important also, Greg, is the patient's angina symptoms too. So another important relationship that we started with, thinking about, well, there's residual angina, there's residual ischemia, there's adverse events. We now see with IFR not only residual ischemia and some focality. We want to know, to your question, so how much of a drop-off is related to how much angina?
Right.
And then how much of that drop-off related to angina is related to events?
Right.
I think that's going to be critical, because at the end of the day, we're going to want to try to think about how do we start to change things, and we'll come to that. But to define right now, I'd say for DEFINE PCI, our next step would be to say, in the short term, is there angina differences related to these changes? And in the long term, or let's say intermediate term at 1 year, is that related to adverse outcomes?
Right, and we know from the FAME studies, at least with FFR, of course, the lower the FFR, the higher the rate of MACE events. We don't have that data yet for IFR, but it's a very reasonable assumption that I'd be very surprised if we don't ultimately show. And so that has implications when we try to define what a threshold is that we should be concerned about. And even with FFR, people argue, what is the threshold? I mean, going up all the way to 0.9 or even 0.93, you can see a slightly increased incidence of adverse events, but the event rates keep going up the lower that you get. So, you've shown us a couple cases here where one, the residual IFR is 0.68. I think that would concern all of us greatly. Another one that was 0.84, and maybe that one's a little bit less concerning. So Alan, do we have enough, or let me ask Habib first. Habib, looking at these data, do we have enough data that we know that we should intervene, that we should be looking for a problem, now based on these insights? And if so, what's the threshold? How do we look for the problem, other than just staring more at the angiogram? And do we act on it yet? Because we're talking, how are we acting on it? Maybe sometimes just a post-dilatation balloon, but sometimes, frequently, it might be another stent, could be multiple stents, and that has cost and potential risk complications.
Oh, great question. So obviously the investigator in me says, no, we don't have the outcomes data to act on it. And I think we first have to wait for the 1-year results, and then potentially, further studies to sort of to guide us. But I think as a clinician, there are a lot of decisions we make in the lab day in, day out for which that exact scenario we don't have outcomes data. You run an IVUS up and down. If you look at the data with IVUS post-stenting, it's never been done this meticulously, where is it distal, is it at the edge, and then how do you react to that? As you well know, because the ADAPT DES, a lot of studies, and yet people use the IVUS data and they act on it. So I think that if I had a patient like the one with the IFR of, I think, 0.68,
Right.
where you have that focal proximal LAD lesion that's identified, maybe the next step would be to go caudal LAO and look for it, or you'd likely want to check with IVUS, but I would be fairly comfortable treating that particular spot. The other thing, I don't know if we've done enough justice to the data, is that last slide. I don't know if it's still showing or not, but the beauty of this study is the co-localization of the ischemia for where you would act in the cath lab, right? Because that's the key part that's really unique about this study. And certainly if someone has a pretty big gradient inside a stent, I think even today, most people would feel comfortable taking a larger post-dil balloon and acting on that as well. So even until we wait for the outcomes, I think that this has been very instructive.
But
the
you know,
one thing
sometimes these stent problems can be tissue prolapse, sometimes they can be edge dissections, and you're not seeing any of this angiographically. Yes, it could be marked under expansion by putting a stent in a fibrocalcific lesion. But I think for me anyway, well look, I routinely image, intravascular image in almost all my stent cases, but for me it's going to make me pull that catheter back and try to find out what's the problem. What's the problem related to the stent? And if there is a proximal or distal issue that I can't see angiographically, I want to confirm that there is an issue there.
I think that's right. I think for where it's in a stent or something like that,
Right.
absolutely. But I think there's still pretty large uncertainty about what to do, right?
Right.
When it's not in the stent, and when there's not 11 pressure drop points in the prox LED,
Right, right.
which I think those two cases are important, but
Yeah.
they may not be instructive. This last case is of interest. You know, there's certainly going to be imaging, but the case where there's 3 drops, and should I do all 3? How many
Right.
points do I need? How does that relate? So I think getting a little bit more of the data out from DEFINE and correlating that to the events will help us guiding what I think is needed, which is, I would say, some way of directing people when they get into that to
Right.
say, this is your roadmap of what you're trying to accomplish. What is the threshold? What's the best you can do? Because it probably won't be a number as much as based on that vessel. How many of those spots can you really treat?
So I guess we're all saying the same thing, that DEFINE PCI is incredibly important. It's shown us that there is this major issue of a quarter of the patients having residual ischemia after otherwise angiographically successful PCI. That may be an explanation of a lot of the recurrent angina that we see and a lot of future adverse cardiovascular events, either stent-related or non-stent related. And the one-year data from DEFINE PCI will be desperately needed. But how we should act on it, whether we should act on it, whether the risks are warranted by the benefits, whether it's cost-effective to act on it, we still can't make firm recommendations. So, Alan, what are we going to do to try to solve that issue of lack of outcomes data?
Well, I mean, besides waiting, of course,
Right.
I think there are some practical implications from the study, which are that we don't always have to react to something, but having the knowledge, I think, is just helpful in assessing the patient and also managing the patient outside the cath lab. Because if you know you had a significant IFR gain, let's say like in the first case, but there is still some residual ischemia which you didn't go after, you know, you might manage the patient a little bit differently. Or I think I agree with you 100% that when you have a repeat IFR and you have that pullback indicating that there might be a focal missed lesion, you have to marry it, in my opinion, with intravascular imaging to really understand what's going on in the vessel. So I think it will have implications just so one understands better the disease process and how to manage the patient long term as well as in the lab.
So, Alan, I think that most of what you've said, while I think we all think is spot on, is what we'd call level of evidence C. And that is, it's expert opinion, and one expert's opinion may be different than another person's, et cetera. So usually with interventional cardiology, I think we've kind of led the way in medicine by developing very robust randomized clinical trial evidence to make firm recommendations to improve outcomes for patients. So what's the future hold for post-PCI IFR assessment?
Well, actually, we're very excited to announce that Philips Volcano is now, based on the DEFINE PCI data, sponsoring the next study, which will be a large randomized trial called DEFINE GPS, Guided Physiologic Stenting. And it's a randomized trial of IFR-guided therapy with pullback and sync vision. Sync vision we didn't talk about, but basically is the co-registration to the angiogram. So the whole procedure is guided by physiology versus standard of care in probably multiple thousand patients. And that will be, I think, the pinnacle of studies in physiology where we use physiology for guidance of PCI.
Great. Mahesh, your thoughts about the potential
Well,
for
I think
this approach?
is moving us. People talk about personalization and precision all the time. And so this is, as we think about what can we do in these procedures to be really precise, this is an opportunity for us to continue to take what is clearly, as you said, a randomized and very well-defined field and continue to mature the technology to standardize how we take care of these patients. So I think this is exciting. I think this is going to be important for the field, and certainly as we look forward to upcoming trials and think about what outcomes we'll see from different studies about managing and revascularizing patients, I think the idea that there's residual ischemia and that we're doing a trial to best optimize that will continue to push the field forward. So I'm excited, and I think it's important. Prior to this, I think we're going to have to work out exactly those definition rules to say that. The second thing about this study I think is going to be important is to also be pretty careful about that second case we saw, where someone has diffuse disease with mild or reduced ischemia. That may be a patient you're not going to treat.
Right.
And that may be a patient in this arm. You're going to have to think about how that works into the study, because I think that's also going to be another important population.
Well, there'll be a lot of details to work out. What do you do when there's diffuse disease and severe ischemia?
Right.
So, Habib, your final thoughts.
No, I'm just to follow on what Manesh said. I mean, to me, I think the IFR-guided arm may not result in longer stents, right? It's not always that you're identifying a new problem that you're going to have to add stent to, because we know that every millimeter stent we place has a cost to it in terms of long-term restenosis and stent thrombosis. But I think that it'll be fascinating to see that it may be that you put shorter stents when you go IFR guided. You just get the correct lesion, you get it up front, you marry it with the angiogram, and as you said, it's precision medicine, right? You're getting the right size stent for the right spot. You're not then reacting to it to say, oh, I see a gradient there, let's go after it. I think that's a critical part, because all the discussion today makes us think that IFR guidance is going to result in more PCI, more stents, but in fact, I think this trial hopefully will show us that it won't. And for someone who's been a physiology enthusiast for 15, 20 years, it's very, very exciting to see that it's coming into the main of clinical practice.
Well, thank you. And it's striking to me you both use the term precision-guided approach or precision medicine. Precision medicine we usually think of as measuring HER2 receptors to guide oncology treatment, et cetera. But to me, this is precision medicine. It's knowing exactly what you should be treating and treating it, not treating more, not treating less, and knowing that you get an optimal result. So, Alan, I want to congratulate you and thank you for leading this very important effort. We hope that you've all enjoyed our review of the DEFINE PCI trial and what's to come in the future, which is very, very exciting. It's very bright. Thank you, everybody.